This presentation is on managing anger and aggression. These are our objectives: to define anger and aggression, to discuss triggers that can produce anger and aggression, talk about techniques to de-escalate patients, and we'll discuss treatment environments that help to promote safety and describe how the imbalance of power and control can contribute to patient regression, anger, and aggression. So anger, although it's a difficult emotion to manage and to experience, it is like grasping onto a hot coal with the intent of throwing it at someone else, but you're the one who ends up getting burned. An important part of what we do in psychiatric nursing is to help with the management of emotions that can lead to behavioral outburst. So anger doesn't have to be a negative expression. It is a normal human emotion. It's problematic, though, when it's expressed aggressively. Anger does tend to vary in intensity. It can be mild irritation and escalate to intense fury and rage. It's often accompanied by physical feeling, and there's certainly biological changes that occur that might include an increase in heart rate, blood pressure, and also energy hormones, adrenaline and noradrenaline can be increased. So these are some important points to remember about anger. It is not necessarily a primary emotion, or it can be something that's learned, especially when we're talking about our response to it. It is a physiological experience, and it's experienced as intense arousal. Anger and aggression are significantly different. It's not that anger is learned, it's the expression of anger and how it's expressed that is thought to be a learned experience. So working with our patients to help them to express anger in healthy ways and helping them to understand that they can have their anger under their own personal control. So we often think of anger and as being negative, but it is, and that's only because it's often linked with aggression. So aggression, though, is one way that individuals express anger, but it can be threatening because people can perceive aggression as a threat to themselves and a threat to their harm and self-esteem. So it can cause damage, of course, if it's physical, but words can also be very hurtful. And then the sequelae, or the outcome, the fallout from expressing anger can be very negative, can lead to relationship problems, can lead to losing jobs, being kicked out of programs, or worse, going to jail, or causing horrible physical harm to folks. So one of the ways that we work with our patients is to help them to understand the origins of their anger. Excuse me. We know that some persons respond in ways that they've learned that can be positive or negative. We know that our earliest role models are often our parents, or whoever was our primary caregivers. And sometimes these role models might, if they're outside of the home, they might be teachers or friends, or maybe groups. And sometimes these can be positive and some can be negative. We also wonder about the influence of video games, violent television, and of course the role of social media in portraying violence and aggression and anger, and how that impacts patient behavior, or in individuals' behavior. So operant condition refers to how behaviors can be positively or negatively reinforced. This is all about behavior, and how behaviors, if they're learned, they can be unlearned through the use of positive reinforcement. They can be unlearned, hopefully, with negative reinforcement. So there are some neurophysiological disorders that can contribute to a person's propensity to act aggressively. Some persons who experience cognitive decline associated with some of the dementias and traumatic brain injury, maybe chronic traumatic encephalopathy, those persons might experience anger and act out aggressively because of whatever's going on with their neurochemistry as a result of some type of an insult like traumatic brain injury or cognitive decline. But we are beginning to understand that there are regions of the brain that are more responsible or play a larger role in the expression of anger. And we learned that out of because we associate them with certain diseases, and we know that based on deterioration of particular structures, that those can be responsible for a negative expression of anger. So brain tumors, brain trauma, encephalitis, people who are experiencing delirium tremens from withdrawal from alcohol, certainly we can see a lot of maybe aggression and violent behaviors. Sometimes certain chemistry can make us more vulnerable to anger. In fact, there are studies that show that males born with low levels of monoamine oxidase can be prone to more violence. And what that means is they do not have the enzyme that breaks down norepinephrine, dopamine, and serotonin, and therefore they have higher levels of circulating monoamines, and as a result, they can be more prone to violence. So they call this the warrior gene. So low monoamine oxidase equals higher circulating levels of norepinephrine, dopamine, and serotonin, and that can contribute to violence in males, but in females, it actually can have an opposite effect. But we know that certain hormones, testosterone and estrogen, can wreak havoc with our emotions, and they play a role in feeling anger or irritability and acting out. We know that socioeconomic factors are a huge reason for violence in our cultures. Certainly those folks in poverty, experiencing substance abuse, job loss, and all the stressors that surround being disadvantaged in a multitude of ways, from education to financial, are more prone to acting out aggressively. Certain environmental factors like overcrowding in cities, places where the temperature is abnormally high or abnormally low, might see increase in violent episodes or increased expressions of aggression. Noise can also lead to increased irritability and expressions of violence. Alcohol can decrease inhibitions and make someone more prone to violent actions. You've heard of some people getting mean when they drink versus those persons who get happy or almost giddy when they drink. So everyone responds differently to alcohol and to a whole host of other drugs. Stimulants might lend themselves to more violent behavior, more aggression. Persons who've had a history of childhood abuse and neglect are more likely to act out violently towards others. History of violent acts with criminal activity. If you've been a person who's committed a past history of violent acts, then you might be at an increased risk for committing other acts of violence. So in assessing patients who are at risk of becoming violent, it's important for us to know the risk factors. So sometimes we'll have patients in the clinical settings, be it outpatient or inpatient, who have been flagged for whatever reason because they have had an episode where they acted out in anger or aggression in the clinical setting. And some people can be banned from coming into the clinical settings if they've had that history and if they've been flagged. And you might have patients who've been flagged as having had a history of violent behavior, and then that will pop up in your electronic medical record during assessment. We have security guards in place in most clinical settings for protection of patients and staff. And, you know, sometimes it's really important for us to know if we have someone who's potentially violent, that we have quick access to emergency services from security. So being able to recognize those signs that someone might be aggressive. So frowning, clenched fist, low-pitched words, forced or clenched teeth, yelling, shouting, intense or no eye contact, hypersensitivity, easily offended. You see them pacing. Those can be signs of impending violence. But sometimes it's hard to see who is going to be violent. It's hard to predict. They can look the same way all the time, go from 0 to 100 in terms on the violence scale. And so it can be challenging to predict. So nursing process. Characteristics of anger include persons being defensive. Sometimes people will act aggressively in a passive way. So they'll, like, you know, it's not directly violent, but it's intimidating and upsetting. So, and we see a lot of passive aggressive types of behavior that occurs between staff. So horizontal violence is can take on the form of being a passive aggressive types of acts, like someone who might deliberately maybe stay longer at a lunchtime, or so that, you know, you won't be able to get a break. Those kinds of actions I know seem small, but when they accumulate, it can be very upsetting. So a lack of control or over-controlled emotions, intense discomfort, flushed face, anxious, tense, angry facial expression. So again, we all experience anger maybe in different ways. And for some people, you can see it readily, others not. And passive aggressive actions are sometimes hard to put your finger on. You know, it might just give you a feeling of, you know, gosh, did they mean to do that? Aggression characteristics can also be identified rather easily when we see someone racing, pacing, and being really restless. And you can see that they're really tense and their body language is very threatening. You might have verbal or even physical threats. And again, this is important for us to be in tune to and to know how to get security to your aid quickly. And sometimes just having the presence of a force, kind of a show of force, can be just enough to de-escalate a certain situation. So threats of homicide or suicide, certainly intimidating, loud voices, shouting, use of obscenities, people being argumentative. It's really important, though, not to be caught up in it and to escalate yourself. So keeping a calm stance and, you know, acknowledging that someone is upset, trying not to be patronizing, stepping back, maintaining safety of all of those persons around you. Sometimes this would necessitate having to relocate patients out of a particular area, especially if you're on an inpatient psychiatric unit. You might have to have patients go to their rooms or to go to a safe place like a common area like the dining room, where it's closed off from that individual. Again, always being mindful of your surroundings. So thinking about those persons and those types of illnesses, symptoms that can produce aggression, that can include someone who's experiencing a panic attack, someone who is experiencing psychosis and having disturbed thought processes. We know destruction of property can that can happen in the clinical settings rather easily. I mean, I've seen a patient in the less than 30 seconds break 2 computers and throw a coffee pot and add a television set and break it all within the course of 30 seconds. And sometimes, again, it's hard to predict just what folks can do when they're completely out of control. So here's anger. It's often is viewed as a single emotion, but it can, exist on that spectrum or on a continuum, starting with feeling minorly annoyed to becoming frustrated, then upset, then irate, then furious, then totally enraged. So these are the risk factors. 3 factors in identifying extent of the risk include that past history of violence, the client's diagnosis. Some diagnoses lend themselves more to an expression of anger. And then, of course, how is that person currently behaving? Prodromal syndromes, when we see anxiety, tension, verbal abuse, and profanity, and increasing hyperactivity, that's kind of that prodromal phase of anger. And looking for rigid posture, clenched fists, jaws, grim, defiant affect, that raised voice, slamming, pounding. These are some of the nursing diagnoses associated with anger and aggression, ineffective coping, obviously, and that's related to negative role modeling possibly, or a dysfunctional family system, or as evidenced by whatever that person is doing. It was yelling, name calling, hitting others, or temper tantrums. And then, of course, there's risk for self-directed and or other violence. So identify the triggers and try to prevent them, or kind of diffuse any triggers. Recognize in patients who might have a tendency towards violent acts, ask them what their triggers are, find out from them, what kinds of medications help you when you're feeling out of control, what kinds of side effects might be contributing to those feelings of anger and aggression. Recognize that when folks have rights taken away from them, like being placed on a locked unit, that loss of freedom can certainly contribute to regression. You think about persons being put on a psychiatric unit. Not only are they not free to come and go, but they can't have all the silverware they might need. They can't have the snacks they want. They can't, maybe, the only activity they have is coloring and crayon and coloring books. And that can be demoralizing for a lot of people. So other people can be triggers. And it's very important, though, if ever there is aggression, violence that occurs in an inpatient setting or outpatient setting, that the staff get treatment, that there's a debriefing and supports available for that person. So know that some other triggers that can lead to violence are withdrawing from substances, the withdrawal from alcohol we mentioned earlier, but also withdrawal from substances like opioids, can produce so much irritability and discomfort that people act out in violent ways. Financial worries, family problems, not being able to have access to your loved ones and your pets, people when they feel ignored, or they are experiencing fear, frustration, mistrust, and anxiety, or a lack of privacy, and when they're feeling judged, can certainly act out in aggressive ways or violent ways. So In the nursing process, what do we do when we're working with people who become angry and aggressive? We want to, you know, try to ignore initial derogatory remarks. That can be challenging though, because of course it's disrespectful, and we feel disrespectful and we can feel angry too. But sometimes that lack of feedback and lack of acknowledging it can extinguish that undesirable behavior. So acknowledge the difficulty they're experiencing, recognize that, yeah, I get it. It's really hard to be here, but you're in a safe place. Acknowledging when people are uncomfortable, because anger doesn't feel good for a lot of people. It's not comfortable. Is there anything that I can do to help you to feel better? And sometimes that might mean that they need a PRN medication like lorazepam to help them to feel calm. What is your biggest concern today is an important question. What is it that's upsetting you? Maybe just removing someone from a stressful situation so that they can walk, deep breathe, use relaxation techniques, or maybe even have some quiet time. And remember, there's always room for negotiation, and that sometimes rules can be broken. Always be flexible. Try not to be reactive, be calm, allow your patients to experience distress and to vent anger. You can try to redirect them, remove stressors, remove patient from the stress, and sometimes remove others from harm's way, and be consistent in your interventions and making sure that all of the staff stay consistent with treatment plan, and be honest with your patients. If they ask you for something for pain or anxiety and you say, yes, I will go get that for you, be specific and consistent with your time frame. So I will get that for you in 10 minutes, or I will contact the doctor and see if we can get you in order, and tell them, you will keep them updated. And again, follow up on that. No one wants to feel forgotten, of course. So talking with your patients when they're aggressive or angry, you can work to talk them down using a calm voice. Don't escalate. Don't be patronizing. Sometimes the last thing you want to hear when you're feeling really stressed and crazy is calm down or just relax. So help them to find something that can de-stress them. It might be a physical outlet like a stress ball, medications. You might need assistance from security or other staff. Only go to restraints if that is the last, as a last resort. If you do need to go to restraints, follow the protocols within your facility, and all of those protocols are in under the ethics chapter. I put in all of the restraints protocols from required by Joint Commission, and there's also a really good chapter on that in your ATI book. Observe documentation, always ongoing assessment, keeping track of what's going on with the patient and in the milieu and how they're interacting with others. And then always make sure you have staff debriefing if there's been any episodes of violence. So as far as psychopharmacology, we use a lot of Haldol for managing aggression. Sometimes we use benzodiazepines like lorazepam, which is Ativan, diazepam, clonazepam, maybe Xanax or alprazolam. Olanzapine and risperidone can also be used. Maintain safety, and sometimes that might mean containment. Sometimes people will like to go to like the quiet room and just have a timeout for themselves. Always protect your staff and other patients. Be aware of your surroundings. Don't be alone with patients, especially with patients that have a tendency towards violence. And sometimes a show of force, meaning the presence of security or a lot of staff around, is enough to diffuse someone from acting out on anger. So patients want to feel in control. Sometimes, before we let someone go, or we might know we're making progress if the client is able to recognize when they're in fact angry. And when they're angry, can they take responsibility for those feelings and keep them in check without losing control? Sometimes, teaching the patients to seek out a staff person or a support person and tell them, I'm feeling out of control. I need space. I need a timeout, or just a place to go so I can settle down, and helping them to find their calm. So interventions, that they're working if your client is able to perform constructive activities instead of acting out in self-destructive or other destructive ways, that they haven't harmed anybody or themselves, and that they're able to solve problems adaptively without a lot of frustration and without becoming violent. So anger is often viewed as a single emotion. However, anger occurs in many forms on a continuum from annoyed to enraged. The tools and skill mirror the emotional continuum that, once it's learned, allow you to use your anger to identify what is not working for you, and then to make healthy communication and behavioral choices. So if you see on this, you see the top scale, and how to manage each one of these points using the toolkit underneath. So in summary, anger, yes, it's a normal human response frequently to abnormal events. For most people, though, anger is uncomfortable and they want help to cope with it. It's a distressing emotion and they don't want to act negatively. So recognizing anger triggers and responding with compassion helps our patients and others to stay safe, bottom line. And anger can be the start of learning coping skills and fostering growth. Thank you.